Good afternoon, and I hope everyone can just, Sade in China, can you hear me?
Yep.
Okay. My name is Robin Kennard, and I'm just here real briefly to talk about the Suicide Prevention Resource Center. Just to introduce you all, excuse me, to the SPRC and to let you know what we're working on for tribal communities. Okay. Well, so the Suicide Prevention Resource Center is a national center, and it is a one-stop source for all of our information, for suicide prevention programs, evidence-based suicide prevention programs, and best practice-based evidence programs. We have toolkits, we can offer trainings, suicide prevention models. We serve communities. We are a national center. We serve the whole country and the territories, communities, tribes, including tribes. In the past, the SPRC was limited to providing training and technical assistance to the tribal Garrett Lee Smith tribal grantees. But that is no longer the case. We are now able to prevent training and technical assistance to all tribes. So our goals for serving tribal programs are China. I was in your NIHB public health conference that you had a couple of months ago, and I was in the workforce development one. And one of the things that really stuck out to me in there, one of the findings on your public health infrastructure workforce development survey was that 45 out of 46 of your responses listed epidemiology as one of your greatest public health infrastructure and workforce development needs. And so between that and the Garrett Lee Smith Tribal Grantee Survey also identified epidemiology as their #1 need as far as training and technical assistance. I'm an epidemiologist, and I feel like I have a great opportunity here to provide some training and technical assistance. We're going to do webinar series, Epi 101. We're going to develop a toolkit, et cetera, to put on the SPRC website for tribes specifically. And I'm really embarrassed because I forgot to introduce myself. I am Crow and Kiowa. I'm enrolled Crow, but I'm from Montana. I'm from Crow Agency. My mom is from Carnegie, Oklahoma. She's Kiowa. And my parents met at Haskell, which is a very, very common story. So in addition to providing training and technical assistance in epidemiology, we're also going to be conducting a tribal needs assessment. And I hope that by reaching out to you all today, you guys will be receiving an email later on this summer with this tribal needs assessment, because we need to develop our training and technical assistance based on what the needs of the tribes are versus us trying to guess. So we want to be sure that everything that we're doing and developing is based on what the tribes have identified as their needs. One of the things that we are going to be doing is working on community empowerment plans. We are actually working with IHS to do this. IHS already has some of these, and so we'll be working specifically with Pamela Endefhorn. I'm sure a lot of you know her, to do this piece. And we are also updating the best practices registry. For any more information, you can visit our website at sprc.org. And if anyone has any questions, I'd be happy to take them as soon as Sade is through with her presentation. Thank you for being here today, and thank you for allowing me to have a piece of this time.
Kwe. Niin Telewisi, Wikamalaman Papukwas. Good afternoon, relatives. My name is Sade Heart of the Hawk, and I am Mi'kmaq First Nation from a small reserve in the north of Nova Scotia called Pictou Landing, presently living on the land of the Quinnipiac Nation in Connecticut. We're going to talk today about the toolkit, what some people call the toolkit for Indian country. I named it the best and promising practices for the implementation of zero suicide in Indian country. But for the sake of brevity, we'll call it the toolkit for Indian country. And we're going to talk today about making suicide a never event. And if you would, for me, and I might not be able to get to the chat, but I would love to know your name and your organization you work for. And if you are tribal, what's your enrollment? If you're Indigenous, please put it in the chat for us. I love to see that. I am Sade Heart of the Hawk, and I am the tribal lead for the Zero Suicide Institute. Had a chance to create this toolkit through a contract we did with IHS, working with some of the tribes to implement zero suicide. It really is an effort, a joint effort, because everything that I heard from the tribes, I tried to incorporate it in the toolkit. But I want to, before we do anything, I want to open in a good way. I have my stage going, so I'm offering some virtual smoke to you, and that's all we can do today. But I want to say a prayer today, this afternoon, to open in a good way, because that's how we do. And this one is a prayer that was given to me in Mi'kmaq, and we translated it to English, and I'd like to share it. Creator, thank you for this day that you've given us. Thank you for allowing us to gather here today. And we ask you to enter where we are so that your teachings will work in us. We ask for wisdom so that we will know what is good in this world. We ask for love so we can spread your love everywhere. We ask for respect so that you will know that everyone comes from one place, and that's from you. We ask for bravery so that we will not be afraid to do your work here. We ask for honesty so that no one will lie or harm any one of us. We ask for humility so that no one will be superior to another. And Creator, we ask for truth so that we will see you in everything we do with clean hearts and spirits. Oh. I want to first acknowledge the losses that we have suffered. And I say suffered, I don't usually use that word, but I will say we have suffered some great losses and some great hurts against us. The 215 babies is 215 plus. I did a workshop this morning, and somebody made mention of the 200 more that were found in Saskatchewan. And I will say to you that the ancestors are talking. There's no more hidden. Everything is coming to light. And as we move together and talk about suicide prevention in our nations, folks who are not native in this field need to understand that we are a people suffering a great hurt, and a great healing needs to happen. So I want to say to these 215 babies that were found in British Columbia, and the 200 more in Saskatchewan, and more and more and more that we're just discovering on a daily basis. I've always known about the unmarked graves at Carlisle Indian School, always, because I lived in Pennsylvania for a while, and I know that's where the prototype is, and we know about them and the unmarked graves there, but our ancestors are talking now. So we believe that every child matters. Our objectives for today, at the end of the session, hopefully you'll be able to differentiate culturally relevant screenings that are resonant with the tribes with whom you're working, and their understanding of what suicide is, the loss of life, and any taboos around language, because that's a huge thing in our communities, in our tribes, around how do we articulate suicide prevention. We're going to hope that you incorporate an understanding of your role in safer suicide care, even if you don't provide behavioral health services, and some of you may not. And we'll talk to you about the 7 principles, the 7 elements of zero suicide. And to me, there's no coincidence that there are 7 of them. and ways that you can ensure that they're culturally relevant with resonant with the indigenous communities you serve and based on the services you provide. So we understand that there's no such thing as native culture. There's no such thing. Throw that term out of your vocabulary if you use it. Here on this side of Turtle Island, we have what, almost 600 federally recognized tribes. We have villages, we have bands, we have nations that are recognized by the US government. We have a ton of them in Oklahoma, where Robin is, and that's third only to Alaska and California, where there are many more. Oklahoma is the ancestral land of 5 nations. So we have 39 in Oklahoma, and 5 call Oklahoma their ancestral land. So what does that tell you? It's a great place for relocation, and that happened. So there are only 5 nations in the whole state that call Oklahoma their ancestral lands. There's lots of tribes, villages, bands, and nations that are in the process of recognition, and some are, many more are state recognized. And every single one of these, except for some what I call universal indigenous truths, has their own language, their own healing ways, their own medicines, their own creation stories, their dances, their songs, their regalia, their beadwork, their colors, and many more things that make them unique. So there's no such thing as native culture, there's native cultures, and one size should never fit all. Here's some of the universal truths that I found working all over Indian country. They're fairly consistent even across the most diverse nations. There's a belief in and reverence for a power greater than ourselves. We call that power different things, call them great mystery, great spirit, creator, whatever you choose to call that power. We believe in and have reverence for a power greater than ourselves. We honor things like the earth. We honor Father Sky, Mother Earth, Grandmother Moon, Grandfather Sun, all of the wing, the slithery, the fins, those that swim. And we believe that everything has a spirit and that we are all related as a result. We honor those who went before us because why? We stand on their shoulders and we call them ancestors. All of us, that's an indigenous universal truth. Our traditional medicines and healing ways are thousands of years old, thousands, and they worked before and they're working again. So we have that as a universal truth as well. We also believe that this conversation that we're having today is going to impact us 7 generations into the future. Why? Because you're going to pass on something. You're going to say, I heard Sade say that. And you're going to pass that on, and someone else is going to pass that on, and it's going to impact the work you do and the way you look at the people that you serve, that you walk beside on their roads to recovery. We believe that everything we do impacts us 7 generations into the future, which is why it's so important to understand that there's layers upon layers upon layers of trauma that need to be acknowledged in order for you to do safer suicide care with Indigenous people. And once you peel back one layer, there's yet another to peel back. Realizing that those 7 generations, I'm only the first generation outside of the residential school. And some people my age, and I'm on my 74th rotation around Grandfather Son, are actual survivors. And I know some of your mothers and fathers and grandmothers and grandfathers and people who are direct survivors or first or second generation survivors often have to struggle with their own healing around intergenerational and historical trauma. But if you don't know that and you try to apply some of the principles we're going to be talking about, it's not going to work very well. So I heard this in a IHS workshop and I loved it. Decolonization is not a concept, it's a practice. We have some of the things that we call intergenerational and historical trauma. On the left-hand side, there's been multiple genocidal attempts on the lives of Indigenous people, including chemical efforts, the boarding school, residential school era, no matter what you call, which side of the Turtle Island, which side of the border you're from. It's called different things, but the effect and the impact was the same. The Indian Wars, forced relocation, and it was so impactful. The destruction of our food sources, criminalization of our ceremonies and our healing ways and our medicine, and then colonization, trying to wipe out the memories of the healing ways and the ways of our people, including language. Our modern day trauma, it's still continuing. Our missing and murdered Indigenous relatives, and in Canada, we say missing, murdered Indigenous relatives and Two-Spirit people. The destruction of our water supplies through assault on them, and there's still places in this country where there's no drinkable water. On my side, there's still water alerts, and we still have to boil our water in order to make it drinkable. The tar sands and the pipelines, and the Dakota Access Pipeline, they told us when we were there at Standing Rock that it was safe, and how many times has oil leaked out into the drinking water. The ignoring of our treaty rights and the sovereignty of our nations, our food deserts. I've been to places around Turtle Island that you have to drive 30 miles to get to the nearest grocery store. And the nearest place to get any food has only food that's not good for you. The Not Your Mascot movement, the 215 plus children who never made it home, and the residential and boarding school era, the cultural appropriation, and again, colonization. Very, very damaging, very damaging. So what do you think? I need you to answer in the chat, and I'm gonna have China tell me the responses, because I can't see the chat and my slides at the same time. So as far as I'm concerned, what's the number that you want to put your number in the chat? As far as I'm concerned, the job of suicide prevention for the people in our communities is primarily the responsibility of whom? Physical health providers, behavioral health providers, the family, faith community, schools, the tribe, or all of the above. What do you think? Put a number in the chat.
I think everyone so far said number 7.
Yeah, that's the safe answer, right? It is. But you're all right. You're all right. It's all of the above, especially in Indian country. Okay, here's a true or false. You put a T or an F. Most people who end their own lives have a diagnosable mental health challenge. For example, depression, anxiety, bipolar, etc. True or false? T or F? What do they say in China?
Got lots of falses coming in.
That's true. It is false. It is false. Most people who end their own lives do not have a diagnosable mental health challenge. It's often a knee-jerk reaction, and sometimes it's an accident. So you're absolutely right. It's false. Most folks who end their own lives saw a physical or behavioral health provider. How many days prior to them doing so? Put the number in the chat. Was it 60? Was it 90? Was it 30? Was it 120? Or was it 7? What do you think? Is it all over the place, Rob? China? I can't hear you.
Sorry. I said there's a few people saying 90, but a lot of people are saying 70. Someone said 30 days.
The answer is 30. The answer is 30. Most folks who end their own lives saw a physical or behavioral health provider 30 days prior to them doing so. So I'm going to talk to you about how we can stop that, how we can close that gap. Okay, and I'm going to do that through best and promising practices for the implementation of zero suicide in Indian country. Again, this was something I was able to create to indigenize the zero suicide framework that's very effective for the dominant culture. It's got 7 elements. There's lots of evidence showing that it significantly reduces loss to suicide in those health and behavioral health care settings. It uses evidence-based screening and assessment, evidence-based treatment. It wraps people at risk and their families in safe care that keeps them connected to the organization. It's person and family directed. And I'm going to talk to you about the planning process for safety. It addresses lethal means safety and transitions people safely from one level of care to the next if they need that. However, all of this is shown to be highly effective, but not for Indigenous people. Why? Because none of these evidence-based screens, assignments, assessments, treatments, or any other of these evidence-based tools were validated on us. None, not even one. Another challenge is many of our languages, including my own, have no word for suicide. Another challenge is that the word suicide, or even talking about someone who took their own life, is very, very taboo in many of our tribes, more than not, because of the concepts of naming. So if you give something a name, you give it life. And in some tribes, and I was at White Mountain Apache when I heard about ghost sickness, why you never talk about someone who ended their own life, because you'll bring that sickness to the community. So they don't even talk about someone who ended their own lives. If you don't know about this, it's going to be pretty hard for you to do suicide prevention in Indian country. One of the things I did early on was to create a medicine wheel with each of the elements in it. And of course, our medicine wheel is very sacred. The circle is a very sacred thing for us because there's no beginning and there's no end. Although there's 7 elements, they're all dependent upon the other. And in the middle is the individual, the family, and the tribe. And I put each of the elements in the emotional, mental, physical, and spiritual realms because they really fit there very well in Indigenous ways of thinking. So here's the element. The first one we usually talk about is lead, because you have to start somewhere. So you have to get a few people together who really believe that suicide can become a never event in your system, in your tribe, in your community. And so the lead element says that you lead a system-wide culture change committed to reducing suicide deaths. Really easy. So, but when we indigenize it, we understand that there's some other things that need to come into play. First of all, when you create a leadership team that's going to put zero suicide into your community, it's done at the system level. The behavioral health system, your FQHC, your health center, your IHS service unit. However, when you indigenize it, you realize that not only do you have to have those folks, but you got to go back and get the chief, governor, president, whatever you call your leader, and maybe the tribal council and the elders and the youth, and they all have to have a part in this, because you don't create something apart from the community when you're working in Indian country. If you don't have the community involved, it's not going to work. And some of you who may have tried that before can attest to that. Some of the ways that people have worked with that was to create cultural liaison positions. Like there's one at White Mountain Apache who there's a traditional healer who works right there with the zero suicide framework and advises them on cultural healing and things that they need to do in order to be able to be resonant with the way the tribe thinks about healing and wellness. And also, he creates an important link back to the tribe, so he lets them know what's going on as well. You have to tailor the information and resources respectfully. I worked, those of you who are Diné probably know about Seattle Medical Center they call it Fort Defiance, but the medical center serves many Diné who are monolingual in Diné. And I think that's the most wonderful thing. They understand that if they don't honor the ways of the Diné, that they're not going to be able to get their Western medicine there either. They're not going to accept it. So what did they do? They actually created a clinic under medicine called traditional healing. traditional medicine, and they employ 4 traditional healers. They have a hogan out in the back of the hospital where they do ceremony. The traditional healers are just as much a part of the medical team as the doctors. They honor the ways of the people, and they realize that that's the way they're going to be able to get their medicine through. But you have to also understand that some people are monolingual in their language. So if you have documents or things that you want to put out into the community, you have to make certain that they're in the language of the people. You need to use the words they use and create open dialogues with the group members. Don't think just because, a lot of folks think, oh, I went to school, I'm a doctor, I'm a PhD, I have the letters after my name. It really means nothing when you're working cross-culturally. And the term cultural humility, we're going to talk about it many times. Part of another element is the train element. So many of us, I'm ABD and a PhD in clinical psychology, and I can tell you I never had not one course, not one symposium, not one lecture on suicidology, not one in all of my years in school. And many folks that are coming out of school have the same story. So we have to make certain that when we're working in a culturally relevant way with the element of train, which says we train a competent, confident, and caring workforce. Well, you can't really be competent if you don't understand the not only suicide prevention, but the cultures of the people with whom you're working. They can't be confident in the work they're doing. And that's where that big gap happens and people fall through. You have to really, when you're onboarding new staff, you should include suicide safer care training. You should make certain that people get the training they need that's appropriate for the position they're applying for. Everybody should do gatekeeper training for non-clinical staff, from people doing billing, from clerical staff, from people working in the kitchen. Everybody needs gatekeeper training. For clinical staff, you want to make certain they understand safety planning and assessment and treatment interventions. But you also want to make certain that they understand the cultures of the people with whom they're working. One of the hospitals uses badge cards that staff wear around their neck so that if they do encounter somebody who's feeling that they want to harm themselves, they know exactly who to call, exactly what to do, and they don't ignore it because they don't know. So everybody feels like they're part of keeping people safe. You want to do yearly inquiries around staff comfort in providing competent care for Indigenous people. And there's a workforce survey, and I actually developed an update for that speaks directly to Indian country. And you want to do this following any major training that you do in your system, and assure staff that these aren't going to be used for performance evaluations. They're really to make certain that you do a good training plan and give people training they need. You also, as I said, and I can't say it enough, that one size should never fit all. Just because you were trained in a model doesn't mean it's going to work with Indigenous people. And each individual culture is different. So you want to find out, you want to be aware of the cultures of the people with whom you're working. Everything, and I say this all the time, everything that is written in books is not necessarily going to work on Indigenous people. And many of our ways have never been studied, and they shouldn't be studied. They should not be researched and documented, because these are sacred ways, but they're thousands of years old, and they work. And it's about cultural humility when you're working with folks, Indigenous folks. Years, but guess what? When I sat with my young relative at Mashantucket Pequot the other day and heard how he articulates health and wellness in the Mashantucket Pequot, I sat there and listened. Because why? I'm not Mashantucket Pequot. I'm Mi'kmaq, and our healing ways may be a little bit different. So I had to have cultural humility. I'm old enough to be his mother, but I had to listen because he was telling me this is how we come back to center when we're not feeling well. This is what health and wellness means to us. So there's encourage cultural sharing between the tribe or the tribes you're working with in the health and behavioral healthcare system and community settings. We're in the process of returning to normal, whatever normal is. And when that happens, we want to participate in the health fairs again. We want to have open houses in our systems and community appreciation events and do our blanketing and have events at the hospital or healthcare setting, go to gatherings, go to homecomings, go to powwows, and bridge that gap between the healthcare and the community. Once you do that, you're going to see that your relationship changes. The community will see you as a partner and not somebody on the outside just to, looking to try to make changes in the community. Identify is one of our elements, and identify says you identify individuals with risk via comprehensive screening and assessment. That's what these are, evidence-based screening and assessment. You want to make certain that you keep in mind that staff implementing zero suicide or implementing suicide safer care in your system may come from the tribal community or the community being served. And as I said, a lot of these tribes have taboos around talking about death. Death in general, but especially death by suicide. Find out if this is the case. If this is the case, encourage Indigenous staff to talk about life promotion instead of suicide prevention or death by suicide. One of your greatest allies is the elders in your community. Find out who they are and ask them for help. How do you do this? Now, Pueblo of Acoma did that. And I'm going to talk about this in the next point. But IHS is promoting the use of the Ask You for screening for suicide risk in their service units. And some of the tribal sites who've been working with the authors of this tool to ensure that the language is resonant, because the Diné people that they were serving at Pueblo of Acoma said, this is where we don't want to talk about this. We don't want people asking us, do you feel like killing yourself? That's offensive to us. And so this unbelievable physical health doctor went to NIMH and the creators of the Ask You and said, how can we indigenize this? How can we change the language without tampering with the validity of it? And they actually worked together along with the elders and the youth of the community to actually change the language of this tool that's out to the world, so that it was resonant with the way that particular group of folks wanted to answer those questions. Now they have it in an indigenized version. You can do that too. But when you choose a tool, you want to make sure that there's representation from the tribe so that you get buy-in and a sense of collaboration. If I'm just at the table just to be at the table and I have no say in what's going on, I don't feel ownership of the product. So you want people to feel like ownership. Again, we're going to talk about cultural humility. There's no substitute for it when working with our people, especially with tools and treatments and screening and assessments that hasn't been validated on us. All of this knowledge assists the culturally savvy clinician with asking questions in ways that will get to the information without damaging the respect and dignity that you've tried to create with people who may be experiencing suicidal thoughts and behaviors while maintaining the integrity of the tool. It's often a delicate balance, but it can be done. Realize that our people are not folks that typically go and ask for help. If somebody does come in and say, I really need your help, honor that. and support it. Make certain that you acknowledge and use ways that make the person know that you are a partner with them and not somebody who's trying to tell them about, what to do, that you will be working with them, and you'll be working with them in a way that honors the ways of healing of their particular tribe and the way they articulate health and wellness, because it may be very different than yours. One of the things I can't stress enough, always ask about the use of traditional forms of healing that show openness and acceptance. Now, it might not be your ways. Maybe you're not even native. But if you ask somebody, you don't use traditional healers, do you? What is that telling them? You're telling them you don't want to hear it. You're telling them you don't believe in it. But it really doesn't matter if you don't believe in it. If they believe that traditional healers will make a difference in their health and wellness, they need to be part of this healing. So you want to make certain that you always have ways to connect with them. Again, like you may have a unit, like so medical center has the unit right there. So if somebody said, yes, I want to see a healer, right then and there, a healer is sent, and the person gets what they need to be healthy and to get back to center. There should be no door that individuals come in where it's closed to them to talk about challenges with risk of suicidal thoughts and behaviors. Most of you probably know that in our communities, when you get to be my age, people take care of us. Our communities take care of us. They see us as wisdom keepers and as people to be honored and taken care of, whereas our children are the ones who are at risk. Just it's flipped from the dominant culture. The children have less of a challenge than do the people who are elders, the people who are in their 60s and 70s who are ending their lives. Our people is just the opposite. So our people my age are taken care of. We have lots and lots of protective factors around us in the person of our people. Some tribal systems use the native acculturation scale that's in tip 59 from SAMHSA. There's 20 questions, which helps you if you don't know, to ascertain how involved is someone with their tribal culture. You want to know this going in, so that way you know how to structure the care. But it should always be person directed. It should always be driven by the person who is the one who should inform how care should go. And you want to use that knowledge to assist the person in accessing that care. And again, you want to make certain that you know exactly how to get in touch with traditional healers in the community. If the person says, this is what I believe that these ceremonies are healing and they're medicine for me, and this is what I want. And there's nothing wrong with that. The next element is engage. We engage all individuals at risk using a care management plan. And that ensures that a clinical pathway is created. We understand what to do when someone comes in and they're at risk. We practice assisting people with a creation of a safety plan that's resonant with their ways of healing. A safety plan is not something a clinician does. It's something that the individual or the individual and their family do. You want to learn to fearlessly counsel on reduction to lethal means safety. Our folks, firearms is not the way that everyone ends their life. And we know that in Indian country, and you need to be able to talk about that. People need to be seen as soon as they're assessed and in need of care. There should never be more than 24 to 48 hours at the very most until they are seen for care. If they cannot be seen within 48 hours by a clinical person, then a peer specialist or a public health nurse, someone needs to be in contact with that person, close contact until a connection is made. Again, safety planning, can be done by anybody. It can be done by a paraprofessional, by peer specialists, by clinical or medical staff. Why? Because the plan belongs to them. This is all in the toolkit, and I know I'm flying through it, but we have very little time. TREAT is another thing. Apparently, you know, we understand that these beautiful treatments for suicidal thoughts and behaviors were not validated on us. So they're evidence-based for some, but not for us. And so understand that for many people, for many of our Indigenous people, the use of those kinds of tools plus our traditional ways are often very highly effective. But if you minimize the traditional ways, it's going to be very hard for you to push forward the other ways, because it's just not going to be, if you don't acknowledge us and our ways, it's going to be hard to have yours as well acknowledged. Telehealth is a real challenge, and something we've gotten really good at in the pandemic. If distance is an issue, telehealth is very, very helpful, and it's often done. There's a huge amount of information on IHS's teleeducation site, and there's a lot of good things that can happen with telehealth. There's oftentimes people say, you know, I can't go to this health center because my whole family works there, and I don't want everybody knowing what's going on with me. So telehealth is often a good way to address that. MOUs with providers in your area, including traditional healers, is extremely critical to make certain that you create this safety net in the community, especially for systems that are more remote and those that aren't full service. If you are tribally owned health and behavioral healthcare system that's not full service, it's really important for you to develop strong relationships with your nearest IHS service unit. Make sure that they're on your implementation team. If you are committed to implementing zero suicide, those kinds of communications with the service unit should be nurtured and supported. The transition element says that we need to connect and keep people connected to our services. It's very, very important. As I said, you use mobile crisis teams, peer specialists, traditional healers, public health nurses, and I saw that a lot with folks who have difficulty with distance or lack of transportation. You want to make certain that people get from one level of care to the other, not a warm handoff, but a hot handoff. If you have to take them or have a peer specialist or someone working in your system take them, it's really a really good idea. You create memorandums of understanding to ensure partnerships with physical and behavioral health providers in the tribe and out of the tribe. And you build relationships with those traditional healers and make certain that they're represented on your teams. You want to send a note, you know, people come in, they leave your system. You want them to know that they can always come back. People create these beautiful postcards with symbols and images from your tribe that convey hope and balance in life. And it's a postcard, and the team signs it with their first name. It doesn't have to have a return address. And there's images that indicate hope. And in some instances, they're in the tribal language. You don't have to put a return address. You want to have the team that intervene with the individual sign it and just say how great it was to meet them, how they enjoyed working with them. Non-demand. It doesn't say, oh, if you don't show up for this appointment, you're out. We kick you out. You want to make certain that people are followed, especially if they're talking about suicidal thoughts or behaviors. They're non-demand. They're in the language of the people being served. They're supportive. They're designed to leave the door open if folks want to re-engage. They're friendly and they're resonant with the cultures being served. Here's one from Chickasaw Nation, this beautiful picture of the Chickasaw homeland. And on the inside, and I don't have a picture of the inside, there's just a greeting. You know, hope you have a wonderful day in both Chickasaw and in English. Not every tribe, the last element is improve, and not every tribe has an electronic health record. I worked with a lot of tribes who are still using RPMS, the system of IHS. It's very, very robust, and I didn't realize how much you can do in it. But even if you don't use a medical record and you're doing it paper and pencil, capture the data. You want to make sure to share it with your staff. What you're doing is helping people maintain their life. It's keeping kids safe and reducing the number of folks who are ending their lives in your communities. You want to make certain that you share that information. Oh, we had 300 intakes and we screened 300 people and we didn't have any deaths, no losses last month, or no losses for the last 6 months. You want to share that not only with the people who are doing the work in your clinic, but also with the tribe or the community in which you're working. It's really important. I'm not a big proponent. I don't like the lost data. I know that's where we have to start. We have to know how many losses to suicide we had in the community and how many of them were in our system. But then you leave it, then you put it to the side, and then you look at process. Okay, how many people did we have come in? How many were screened for suicide risk? And those who screened positive, how many had an assessment done that was culturally appropriate for the people we serve? You want to take those numbers and then look and say, okay, we had 65 losses in our tribe in the last 5 years, and in this last year we didn't have any. Is it because we're doing these screenings? You want to find out what to attribute that to, but you're not going to know unless you collect the data. The CACs, for those of you in IHS-led health or behavioral health systems, know about the clinical applications coordinators. If you have one of those, you have gold. They really are very, very helpful, and they can help you, especially if you're using RPMS. IHS has office hours a lot with our RPMS, and they help you to create pick lists. So not only will your services be paid for, but that you can extract data for it. You want to make certain that you look at 4 or 5 data points that's going to let you know that that the work you're doing is making a difference in the lives of the people you're serving. In the toolkit is a data elements worksheet with information about what are the things you should collect that's going to help you. What's the low-hanging fruit that you can start to collect right now? Even an old medical record system has functionality that if somebody in your IT department can unlock it, and if they have capacity, the CACs have also assisted not only IHS-led, but tribally owned and managed health and behavioral health systems, especially those who use RPMS. If you have one of those available to you, like I said, he or she is gold. You want to share the data with the tribe, with the community. You want to tell them and show them that what you're doing is making a difference, but you want to have them at the table. This data can be published in tribal newsletters, presented at community gatherings, in infographics, at health fairs, but you want to share it. One of the things I want to leave you with is that our people are resilient. No one has endured the multiple attempts at genocide that we have, and we're still standing. We're still standing strong. We want you to understand, and we want, for those of you who are not Indigenous, that if you make your care resonant with our healing ways, our ways of knowing, our people are going to continue to thrive and grow. Our children are going to cease to end their lives. We reach back into the root system, the ways of the ancestors. And for some, that's not easy. But our ways have always kept our people alive and thriving. And we want to return to that healing and wellness, that state of being of centeredness. And through looking at the way you're providing suicide safer care, or even starting to think about it. And you can do that. We at the Zero Suicide Institute can help you do that. You're going to ensure that people live and continue on and thrive, and they grow, and they continue to move forward as the great nations that we know and love. So with all of that said, China, if we could open it for questions. I know that I've run through this, but I want you to know that the toolkit is available. It's on the Zero Suicide website. And it is available for download, and we are available for consultation and training and education and workshops and academies that are specific to Indian country, that look at the ways of our people and realizing that there is no one size fits all, but understanding that these evidence-based ways really need to be reframed in order to be resonant with the ways of our people. Questions, observations?
All right, it looks like we do have some questions rolling in. Someone asked, is there a way to get the copy of the ASQ that's geared towards Indigenous perspective? They said they did a quick Google search but couldn't find it.
I would contact Dr. Narit Harari at Pueblo of Acoma, or Lieutenant Commander Monica Edwards at IHS. She is now leading the Zero Suicide Initiative for IHS. Lieutenant Commander Monica Edwards. She took over for Commander Sean Bennett, with whom I worked. And she now leads the Zero Suicide Initiative. And that system is the one who actually did the indigenization of the ASQ. I think it's probably still too new to actually be on the website. I think they're still, they said you can use this with validity, but I don't know that NIMH has actually published it as yet. But certainly, you know, it's a great tool because it really used the language that the elders and the youth said that they wanted used. Don't ask us, do you feel like killing yourself? That was jarring to them. It was offensive. And so now they ask, have you felt like taking your life, or something like that, something much less jarring.
Thank you for that. And it looks like someone has their hand raised, so I'm going to unmute Leah if you wanted to ask your question. I don't think we can hear you.
Can't hear.
No.
Oh.
All right, she's going to type the question.
Okay. I see another hand.
Oh, yes. All right. Carrie, you can unmute yourself.
Hi, Sade. Thank you so much for this really valuable presentation today. So I have an art therapy, it's called Startup Art Therapy to Rewire Your Brain. It's a program that I've been implementing in the tribal schools for years. And one of the things that I found is that in the tribal classrooms, one of the challenges we've come up against is that when we've gathered, and not just in the reservations I've worked in, but a few reservations that I've worked in and lived in, one of the things that has happened is that the teachers kind of fizzle out, that they don't implement what they've learned. And for example, one of my friends and colleagues, she was a principal at a Pine Ridge school, and she says, oh, we're going to another trauma training next week. And I said, well, geez, you guys are going to these every other week. How do you implement what you've been learning, and how do you stick with it? So I'm wondering, do you have any ideas or feedback on that?
Yeah, you know, it's, you know, we we need to implement the sanctuary model with each other. Those of us who are Indigenous are well aware, or many of us are, especially if we're working in behavioral health, know about the impact of trauma and how it's passed down generationally, and as well as what's going on right now. As I showed you the list on the right of things that are going on with us right now, that we really need to, especially in these times when there are so many challenges, we need to make certain that we are practicing this with each other as well. You can't fill somebody else's glass if yours is empty, you know? So we need to have our own healing together. Those of us who are doing the work, we need to heal too. And you can't listen to stories from people who are losing everything, who are struggling with alcohol or other drug challenges, who are living with mental health challenges. One of the things I didn't say was that I'm a person in long-term recovery. Last time I put a needle in my arm was 51 years ago, and a mental health challenge and multiple suicide attempts, but I'm not unique. But I have my community. I can talk to my community, because guess what? Many of us have that same story. But if we internalize it and just keep it to ourselves, if we don't share, if we don't process what we're hearing and what we're seeing every day in our communities, that's when people fizzle and burn out. So we really need to be as intentional about our own healing as we are of the healing of the people we serve. That's what I would say, Carrie. That's my advice.
And I did get Leah's question in the chat. She asked, what pilot programs are there that are geared towards suicide prevention that are Indigenous?
IHS has the Zero Suicide Initiative, and they fund, it's not a grant, it's an award. They fund tribal organizations who are ready to implement zero suicide. So I would keep an eye out for that. And SAMHSA is always doing Native Connections grants. They're doing Garrett Lee Smith grants, and they really want tribes to apply for these things. So there are a number of things, and SAMHSA understands that it's our children that we really have to pay attention to and that we're most concerned about. And so a lot of their grants and their awards are geared toward children. So there are lots of things. And I would urge you to stay in touch. Go to SAMHSA's website, SAMHSA, and look at what they have as far as offerings. There are people on this call today who are recipients of Native Connections grants and Garrett Lee Smith grants for children, specifically to target our children. So there are opportunities, but you can start with IHS. Pam Endofhorn, Penny, I call her Penny. Pam Endofhorn is a phenomenal person to get in touch with. She's the national lead for suicide prevention for IHS, and she can let you know what's going on as well. She's Rosebud Lakota, a phenomenal woman who really has her heart in suicide prevention for our people. So there's those opportunities. And believe me, this is the time. There's lots of COVID emergency grants that some tribes have taken advantage of. I'm working with the Chickasaw Nation who got a COVID emergency grant to do suicide prevention in the tribe and in the surrounding tribes in Oklahoma. So I'm working with them. So there's a lot of funding coming down, and a lot of it is targeted to our people because these government entities understand that we have a challenge and we have unique ways. Our ways need to be paid attention to when we're looking at addressing in a culturally resonant manner. Anybody else, China?
Yes, we have another question. Someone asked, do you have a briefing or program for those of us that are active in crisis response teams?
I'm working with some crisis response teams right now, one of them in the state of Iowa. The crisis response teams are really, they can do zero suicide too. So this is relevant to you as well. Just because you're not doing behavioral health care, you still can do zero suicide. You just have to find somebody who can do the actual treatment, but everything else you can do. The state of Oklahoma has a crisis response team they call Heartline, I think it is. Those of you in Oklahoma can verify that or deny that. But I know that Chickasaw Nation contracts with them to do their follow-ups. So not only do they connect people to care, but they can also do a screen, a suicide screen. They can also do an assessment if there's a master's level person or above on the team that can actually do an assessment to see, does this person really need to be in the hospital, in the emergency department, in a psychiatric hospital, or did they just need to do a safety plan and to get some counseling on access to lethal means, and then some good suicide safer treatment that we can refer to this treatment provider with whom we have a relationship. So you can, a crisis unit can do just as much or almost as much as a behavioral health provider or a physical health provider when it comes to safer suicide care. So I would say to you, check out the toolkit, and you can find yourself in there a lot. There's lots of ways that you can connect to be, and there's some very simple things in there that will tell you, is this for me or is it not for me? There's some worksheets, there's some culturally appropriate worksheets, to look at your own system and say, this is something we could do as well. So I would urge you to do that. Go to the toolkit and look around in there and see what's, you're going to find a lot of things that are resonant and relevant to you as a crisis response unit.
And we have one last, comment. Someone says that when the zero suicide first came out, it involved a lot of different hospital staffs and different departments in order to get started. But as times go on with the pandemic, everyone seems to be a little bit busy. I guess maybe do you have any suggestions on, sorry, my dog, what to do about that?
This is a very, very, very different time. Relatives, this is a very different time. We've had to come up with responses. We've had to come up with new ways of delivering care. We've had to come up with ways to make certain that our own staff was safe. I've seen staff losses since the pandemic. I never saw that as an issue before. When, all this work that I do with zero suicide around Turtle Island, I've never seen issues like I've seen in the last year with actually staff ending their own lives. This is a very, very difficult time. So I would say that it's not an initiative, it's not a project, it's not something extra I have to do. It's a way to look at the way services are delivered and make certain that we close those gaps. Like I said, the folks who are in their life by and large, end their lives within 30 days of seeing a provider. What does that tell you? It tells you we're not asking the questions. So it's really not a project. If people are able to look at it not as a project, but as a way that we can rethink the way we deliver services. And if you are JACO certified, or if you're certified by CARF or any of those other accrediting bodies, they directly mention zero suicide as a framework for safer suicide care. So, you get extra points when you are noted by JACO as a provider that does safer suicide care. That's another designation. So it's not like we just came up with this and said, oh, here's something else that we're going to pile on the poor providers. One of the things that I said early on to you is I've been doing this for 51 years, not doing zero suicide, but doing care. I understand the challenges. I understand how, if I'm putting something else on your platter, not a plate, but a platter, you're just going to see it as one more thing that you got to carry. That's not going to work. So if we reframe it to say, you know, we really believe that care needs to be person directed. It needs to include the family. In Indian country, it needs to include the community. It needs to include elders. We need to be informed by our youth. All of those things that we really believe in, we're going to be successful. And for me, it's all about taking care of those babies. And I know for a bunch of folks in here who are doing the work already, that it is as well. So I really appreciate you. I say Walalio to all of you. Robin, thank you. It was wonderful to see you and to know that SPRC is in great hands with the work being focused on Indian country and keeping our people safe. And just be good to each other, be nice to each other. You know, this is a different time, relatives. This is a different time, and one that we don't have any frame of reference for. You know, I know people my age have, you know, we've never had anything like this, never. So we've had to come up with new ways to think about the work we do. And it's not always easy, but people are still losing their lives. So what are we going to do? This is a way to stop that. And it's not, the time to do this is not when there's a crisis, not when you had a cluster of 5 or 6 children and their lives. The time is now. You want to get ahead of that. You want to make certain that you create this framework in the community. And it's not just the health or behavioral health care program. Certainly not. It's the community. It's the elders who are keeping the language alive and doing ceremony and praying. And it's the children who are saying, you know, this works for me. That same physician who did focus groups with the elders and the kids, they got from the kids, yeah, you can screen us, but we don't want anybody around. You have to do it in private with the door closed. We don't want anybody to hear. And she listened to that, and they said, and even if we're negative, we want you to give us a list of resources so that we can give them to our friends, because they know that there's a challenge in our communities, especially with our children. I thought that was powerful. I'm like, what a beautiful message. You know, they told them exactly what they wanted and how they wanted it. We need to listen to that. Thank you. Wilaliok. This has been a pleasure. Thank you, China. Thank you, National Indian Health Board, for reaching out to get more information on this toolkit. Please go and visit the toolkit. Watch the videos, especially the one from Lawton Indian Hospital and the one from Sehotso Medical Center, and see that wonderful work they're doing. It's tremendous. Wonderful work is happening in Indian country. We can do this together.
I want to thank both you, Sade and Robin, for a wonderful presentation, a great way to end a long day of learning. It was just wonderful. I did want to remind everyone to sign out if you are trying to get your CEU credits. Do sign out. I'll put the link in the chat so you can just access it that way. And then fill out the evaluation form. But I really appreciate this presentation. Sorry.
I wonder, China, if Robin has any parting words, since we have a few minutes, actually. Oh, no, we don't. We're overtime, right? Oh, shoot. I'm sorry.
It's okay. People are still on, so you guys are doing something right. So it's okay. No worries. Robin, did you have anything to say?
I just, your presentation is fascinating. And so I'm just honored and humbled to be listed with you and to be here presenting with you. And I really appreciate you and all the work that you've done. And I was particularly thrilled when you started talking about data and the need to collect data. And that is something that we at the SPRC will be able to help with. If tribes just reach out to us. So we're here, I'm here, and thank you for letting me be part of this.
Yes, thank you guys again. And I hope everyone has a great day and stay safe and just enjoy the rest of your evening.
Thank you.